Hello everyone and welcome to your channel of pharmacology, where today we will be discussing about the diuretic action of carbonic anhydrase inhibitors. So without taking much time, let us begin. Now students, before moving forward, let us understand what do we mean by the term diuretics. Now diuretics are those drugs that are going to increase the rate of the urine flow. This is very important. Now the clinically important diuretics that we use, the clinically relevant diuretics, they are the ones that are going to increase the rate of sodium excretion as well as an accompanying anion such as chloride. Now why will this happen? This will happen because the water is reabsorbed in the nephron passively, right? So with the reabsorption of ions, the water is being reabsorbed. So naturally, if you stop the process of reabsorption of the ions, along with that more water will be excreted, which is the primary target for diuretics, right? Now students, there is another concept, and that concept is known as diuretic braking. So let us understand what do we mean by that. We have already studied that there will be a loss of sodium ions on because of diuretic action, right? So if there is continued diuretic administration, naturally there will be a net deficit of sodium ions in the body. But this time course of natriuresis, or the loss of sodium ion in the urine, this is finite. Now why is it finite? Because there, as the sodium ion is being lost from the body, the renal compensatory mechanisms, they will be activated. Now because of the activation of these renal compensatory mechanisms, they will ultimately bring down the sodium excretion in line with the sodium intake. That is, sodium excretion will equal the sodium intake, and this concept is known as diuretic braking. Now the drugs that are used as diuretics in case of carbonic anhydrase inhibitors are acetazolamide, dichlorphenamide and methazolamide. We also have two other drugs, that is brinzolamide and dorzolamide, but they are used in case of open angle glaucomas. Now students, here you can see a very familiar diagram of a nephron. You have seen it a million times. So now there are a few points that I want to raise on. Firstly, the diuretic, the carbonic anhydrase inhibitors, they act in the primary site of action is in the proximal convoluted tubules, right? Now if you study the structure here, then suppose as you can see that this entire nephron, this is surrounded by the renal artery and the renal veins, right? So suppose I'm talking about a cell here. Let us suppose that we have got an epithelial cell here. So an epithelial cell here, it will have two surfaces, right? Please excuse my drawing. So epithelial cell here will have two surfaces. The first surface will be the one that will face towards the lumen, right? So suppose here we have the lumen, the tubular lumen, and this surface is known as the luminal surface because it is facing towards the lumen. There will be another surface that will be away from the lumen, and that surface is known as the basolateral surface. So a cell with an epithelial cell with a nephron will have two surfaces, one that is towards the lumen known as the luminal surface, and another one which will be away from the lumen, and that is known as the basolateral surface. Now students, as I have already told you that the primary site of carbonic anhydrase inhibitors is the proximal convoluted tubule. Now in the proximal convoluted tubule epithelial cells, they are rich in the zinc metalloenzyme carbonic anhydrase. This carbonic anhydrase is present in two principal sites. The first carbonic anhydrase is present in the luminal and the basolateral membranes of the epithelial cell, that is known as type 4 carbonic anhydrase. And the carbonic anhydrase that is present within the cytoplasm of the epithelial cells, that is known as the type 2 carbonic anhydrase. Right? So suppose this is an epithelial cell, and this is where the lumen is. So this will be the luminal side that we have already discussed. This will be the basolateral side. So one carbonic anhydrase is present here, and that is the type 4 carbonic anhydrase. Another carbonic anhydrase is present within the cytoplasm, and that is the type 2 carbonic anhydrase. Now the role of the carbonic anhydrase is that this helps in the sodium bicarbonate reabsorption, and this action primarily happens in the proximal convoluted tubule, where the sodium bicarbonate that is reabsorbed from the lumen to the interstitium. And the second role of carbonic anhydrase, that is secretion of titrable acid, and this happens in the late distal tubules, but this is the secondary site. The primary site of action is the PCT, and the primary action is the sodium bicarbonate reabsorption. Now students, before moving forward, let us understand what is the mechanism of action of carbonic anhydrase inhibitors. So now let us suppose that this is the epithelial cell. The epithelial cell of the proximal convoluted tubule. And let us suppose that this is the tubular lumen. So naturally this side that is facing towards the lumen, that will be the luminal side. The one that is away from the lumen, this will be the basolateral side. So now in the luminal side, you have got an antiporter. What's an antiporter? Antiporter is something that is going to move the ions in opposite direction. Now this is an antiporter, that means that it is going to act as per the concentration gradient. Now the concentration of sodium inside the cell is lower, and the concentration of sodium in the lumen will be higher. So it is going to move the sodium from the lumen to the cytoplasm of the epithelial cell, and in exchange for this it is going to remove H plus from the cytoplasm to the lumen. Now in the lumen, bicarbonate has also been filtered at the glomerulus. So now this bicarbonate that has been filtered at the glomerulus and the H plus that has been secreted into the lumen, they are going to react to form carbonic acid, and this reaction is catalyzed by carbonic anhydrase type 4. Now this carbonic acid, it will ultimately disintegrate into H2O and CO2. So the final product is, you have got H2O and you have got CO2. Now this CO2, it is lipophilic. That means it is going to cross the membrane and ultimately it will move into the cytoplasm. Now into the cytoplasm, this CO2 that we have, it is going to react with the water present in the cytoplasm, and ultimately it is going to form carbonic acid. This reaction is catalyzed by carbonic anhydrase type 2. Now if you look carefully, the proton, the H plus, that is getting lost because of this antiporter. So inside the cytoplasm, the concentration of H plus will be low. Now to compensate for this low H plus, the carbonic acid, it will spontaneously disintegrate into H plus and bicarbonate, HCO3 minus. So now see, you have got sodium here, you have got bicarbonate here. So now this sodium and the bicarbonate, they will together be reabsorbed into the interstitium. So because of carbonic anhydrase, the bicarbonate that was present in the lumen, now that has been reabsorbed into the interstitium. Now along with sodium and bicarbonate, water will also be reabsorbed. Why water? So that the reabsorption is isotonic. Now this water will be reabsorbed from the lumen. That means now the concentration of water in the lumen, that will be low. Now since the concentration of water in the lumen is low, you have also got chlorine in the lumen. Now since the concentration of water in the lumen is low, the concentration of chlorine will now increase. Since the solvent is low, now the solute, naturally the solute will be more concentrated. So now this chlorine, it will also be reabsorbed by a paracellular pathway. The chlorine will move from a region of high concentration to the one where the concentration is low. So ultimately, because of carbonic anhydrase, we have actually reabsorbed the sodium, bicarbonate, chlorine and water, right? The carbonic anhydrase inhibitors, they are going to inhibit the type 2 carbonic anhydrase as well as the type 4 carbonic anhydrase. Both the carbonic anhydrases will be inhibited by the carbonic anhydrase inhibitors. So now since the carbonic anhydrase has been inhibited, so naturally bicarbonate cannot be reabsorbed, right? Now if bicarbonate cannot be, the reabsorption of bicarbonate again will not happen. Now see that this carbonic anhydrase was the one that was providing the proton for this two antiporter to act, right? This is going to supply the protons, but since this has been inhibited, now the supply of protons will not be there. Since the supply of protons will not be there, ultimately the antiporter is also not going to function. If the antiporter does not function, naturally the sodium will also not be reabsorbed, right? And the H plus will not be secreted into the lumen. If the secretion of H plus is not there into the lumen, again this reaction will also not happen. So ultimately the carbon dioxide is also not going to come inside. So finally all what was supposed to be reabsorbed are not going to happen, right? Because of carbonic anhydrase inhibitors. Now students, let us see what is the effect of carbonic anhydrase inhibitors on the urinary excretion of the ions. Now before we move forward there, one thing to note here is that we know that in our body the enzymes, they are in excess. Now carbonic anhydrase is also an enzyme. That means carbonic anhydrase is also present in excess amount in the PCT. That means for a clinically significant effect to occur, large amount of carbonic anhydrase needs to be inhibited. Now once this has happened, let us see what is going to happen. Now because carbonic anhydrase has been inhibited, the reabsorption of bicarbonate will now not be there. That means increased amount of bicarbonate will be present in the urine. So there will be a rise in the urinary bicarbonate excretion, and this rise will be 35% of the filtered load. Now since there is presence of bicarbonate in the urine, the urinary pH is going to increase, and this will increase to about 8. Now the bicarbonate was supposed to be reabsorbed from the lumen into the body. Now that is not happening. So naturally there will be metabolic acidosis. We also saw that because of this phenomenon, the carbonic anhydrase inhibition, there will ultimately be increase in chlorine excretion as well. We also saw that there is increased amount of sodium excretion. Now this increased amount of sodium excretion in the later part of the distal tubule, some part of the sodium will be exchanged for potassium. That means that because of carbonic anhydrase inhibition, there will be increased loss of potassium also in the urine. Now students, remember a very important concept here: maximum kaliuresis, or the presence of potassium in the urine. Maximum kaliuresis is caused by carbonic anhydrase inhibitors. That means carbonic anhydrase inhibitors, they can also cause maximum hypokalemia. These two are very important for your MCQs. Now another interesting point to note here is that the diuretic effect of carbonic anhydrase inhibitors will be self-limiting. Now why self-limiting? Because the diuretic effect of carbonic anhydrase inhibitors is dependent on bicarbonate, the amount of bicarbonate that is present in the lumen, and the amount of bicarbonate that is present in the lumen is dependent on the filtered load of bicarbonate. That is, what is the amount of bicarbonate that is reaching the glomerulus for being filtered. Right? The filtered load of bicarbonate, what is the amount of bicarbonate that is reaching the glomerulus for filtration? Now since there will be increased urinary excretion of bicarbonate, that means the amount of bicarbonate in the body will be low. Since the amount of bicarbonate in the body will be low, the filtered load of bicarbonate obviously will be low. That means bicarbonate now will not be filtered. The body will try to preserve the bicarbonate, right? Since it is already low amount in the body, why the body will try now to preserve this bicarbonate? Now since the bicarbonate will be preserved, naturally the action of carbonic anhydrase will also not be there. That is why the diuretic effect is self-limiting. Please remember students, this is another very important MCQ. Now if you look into the pharmacokinetic data, we have got 3 drugs: acetazolamide, dichlorphenamide and methazolamide. Now the relative potency of acetazolamide, if it is 1, it is almost 100% bioavailable. The T half varies from 6 to 9 hours, and the route of elimination is primarily renal. Now dichlorphenamide, the relative potency is more, but there is no sufficient data for rest of the parameters. In case of methazolamide, the relative potency is greater than 1 but less than 10 with respect to acetazolamide. The oral bioavailability is also close to 100%, and the T half is again more, that is almost 14 hours, but the route of elimination is primarily through metabolism and very less through the renal. Through the renal system, these drugs are exchanged as it is in an unchanged form. Now students, let us see what are the therapeutic uses of carbonic anhydrase inhibitors. Now the drug acetazolamide, it is primarily used in case of high altitude illness or mountain sickness. A new drug, that is dichlorphenamide, it has been approved for familial periodic paralysis. Now this is also a potential MCQ. These drugs are also used for the purpose of alkalinization of urine. Now what do we need it? In conditions where the urine will be acidic, such as UTI, and when we want to excrete the acidic drugs. Now as I've already told you, in case of open angle glaucoma, and we have got two very specific drugs for that purpose, they are dorzolamide and brinzolamide. Now students, let us have a look into the adverse effect of these drugs. Now in terms of the ions, this drug can cause hyponatremia. They are going to cause maximum amount of hypokalemia among all the diuretics. They are going to increase the bicarbonate excretion in the urine. That means the amount of bicarbonate in the body will also be lower. They are going to increase the chlorine excretion in urine. That means amount of chlorine in the body will also be lower. Other than that, these drugs can cause bone marrow depression and skin toxicity. In higher doses, they can cause drowsiness and paresthesias. Now, because of the increased amount of bicarbonate in the urine will be alkaline. We have already studied that. So now, since the urine is alkaline, that means the amount of H plus in the urine is low. So now the ammonia of renal origin was supposed to interact with this H plus, combine with this H plus and form NH4 plus, which was non-toxic, and this one was to be excreted in the urine. Now since the amount of H plus in the urine is low, NH4 plus will not be forming. That means NH3 will keep on accumulating in the urine. Now this NH3 that has been accumulated in the urine, it will now shift from the urine into the systemic circulation. That means now within the body the amount of ammonia is going to increase, and we know that if the amount of ammonia increases in the body, it can lead to a dangerous condition, and that condition is known as hepatic encephalopathy. Now the chances of development of hepatic encephalopathy is more in case of patients with cirrhosis. So this drug is contraindicated in patients with hepatic cirrhosis. Why? Because of the chance of development of hepatic encephalopathy in them. Now since the urine is alkaline, hence there is an increased chance of precipitation of the calcium phosphate salts in the alkaline urine, and this can lead to the formation of calculus and development of ureteral colic. So this drug is not to be given in patients who have got calcium phosphate calculus already. Now this drug, it can also cause metabolic acidosis. Hence if the patient is having either metabolic or respiratory acidosis, it is going to worsen the condition. So that is why this drug is not given in case of patients with hyperchloremic acidosis or in patients who have got severe COPD. So we don't give this drug to patients with hyperchloremic acidosis or to patients with severe COPD, because the chances of worsening of acidosis is already there, right? So that's it for today everyone. If you like the video, then give it a thumbs up. Also share it among your friends. Do subscribe to our channel and press the bell icon so that you don't miss out on any more upcoming videos. Also let us know down in the comment below what other topic you would like us to discuss. We will meet you again very soon with more such videos. Until then, goodbye and take care.